All right. Well, it looks like we got a great group on here already. So good afternoon, everyone. Welcome to IPHA's third Lunch and Learn web series. And my name is Jenna Heyer. I am a member of the IPHA Education Committee. And I just want to thank you all for joining us today. This is actually the second session of our fall series, and we have a great fall series planned. So I hope that you can join us each month. This session is being recorded, and we will be posting it to the IPHA YouTube channel following the session. So I have a few more coming in here. I'm going to wait for everyone else to get admitted and connected. Just a few housekeeping items. Please mute yourself during the presentation. This just keeps the bandwidth enough so that we can see Sarah and her presentation. Feel free to put questions in the chat or the Q&A feature on Zoom. And there's going to be plenty of time at the end for live discussion, where you're welcome to take yourself off mute and we can just have discussion and talk about health equity. So I want to introduce Sarah. We are joined by Sarah Dixon today, who's the Senior Director of Partnerships and Development with the Iowa Primary Care Association. Sarah is going to speak with us about health equity, the health equity journey of Iowa's community health centers. So like I said, there's going to be plenty of time for discussion at the end, but for now, I'm going to hand it over to Sarah to get us started. So thanks for being here, Sarah.
Thank you, Jenna, for having me, and good afternoon, everybody. It's super fun to see some names I know, and it's an honor to be part of the Iowa Public Health Association Lunch and Learn. I was really bummed to miss the last one on community health workers, and so really think it's like a great agenda that IPHA has put together. I'll be talking today about I'll give you a little bit of information just to level set on who health centers are, kind of who we serve, and the role of the Iowa Primary Care Association, and then taking you through some slides that just try to convey and illustrate the journey we've been on. I told Jenna I would try to wrap up with the content by about 12:30, so we have a lot of time to discuss. I feel like in these conversations, it's all learn, all teach, and so coming in with our experience, but knowing that we have as much to learn from all of you as we continue our work. So just going to the next slide, this is just some really overview statistics about who health centers serve. So there are 14 health centers in the state of Iowa. They are located all over the country, in every state and territory, and this gives you a sense of kind of what role we play in the state in terms of healthcare services in 2022. I love this slide because it shows the integrated model that health centers do try to deploy, where they're bringing not only medical, dental, behavioral health, but even increasingly pharmacy, vision services, and of course enabling services that kind of are designed to break down barriers to care. This again is just one other level setting slide about kind of who we serve and the breakdown of some of the demographics. We do have additional data, but this is a nice just summary of kind of who we're serving across the state between adults and children, veterans, patients experiencing homelessness, and then also looking at the insurance status, particularly the Medicaid program. This is a map of where the Iowa health centers exist, or where they're located, and the little pins are kind of satellite sites, with the bigger marker being the main clinic sites. So you have a sense of kind of what communities the health centers are in, and some of the states that they even are providing care in outside of Iowa. So I work for the Iowa Primary Care Association, which is really the trade association or of the federally qualified health centers, and there is a PCA in every state that really supports this model of care and the system of care that really is supported by our federal partners at HRSA and all of our payers and partners in our local community. So our vision is health equity for all. We established that vision early in 2019, and we have a mission of enhancing community health centers' capacity to care. And then I want to also share our values as an organization, which all of our staff really help to define, like, what does that mean to us when we talk about respectful as an example. And then again, just one more kind of background slide about who we are at the Primary Care Association. We do have two sister companies. So one is called In Concert Care, and it is a health information technology focused company that really hosts a lot of different HIT systems and services and supports on behalf of our health centers. And then we also have a third company called Iowa Health Plus, which is a limited liability company and goes into really the value-based contracting with payers. And then the PCA, it plays kind of a traditional association role in the policy and advocacy space, lots of quality improvement, workforce development, communications, and then also looking for opportunities to meet the needs of Iowans by expanding the health center model of care. Wanted to share the key drivers of our work. So this is right out of our strategic plan. And we really have 5 goal areas. So preparing for the future, optimizing data, advancing value-based care, investing in people, and last but not least, advancing health equity. And so the work that we do within our strategic plan all falls under these 5 key areas. And the way we do our strategic planning is to have projects that we're advancing kind of that support these overarching goals. So we're here to talk about our health equity journey today, and wanted to share kind of what's our why for health equity. And addressing health equity is for our patients, our communities, and all the people who work with us. We're focused on hopefully building out better systems in the future. And we know that this work cannot be done. We cannot do this work alone, and we need a lot of different partnerships from a variety of sectors to be able to make an impact in this space. Historically, health centers came out of the civil rights movement and the war on poverty, and so have had addressing inequities as part of the core of their work really since the model was came to the United States from South Africa. And I think we are seeing kind of a reemergence of the role outside the 4 walls of the clinics that health centers can take to advance the space, in today's environment. We know in a state like Iowa that place matters. It matters everywhere, but rural areas in particular experience some of the most prevalent disparities and lack of access to services and care. Even though we know those things are happening in our more urban communities, it's particularly acute in our rural areas. And then we of course look at what inequities cost the system. And I think all of you that are public health practitioners, this is the bread and butter of public health, which is, can we do things to prevent these like costly situations from occurring, and in this case, these costly situations that are occurring as a result of people not getting the same care or the same level of treatment or the same access that they need, and our practitioners or our systems also not being able to really meet the individual where they are in terms of the care that they want for themselves, their families, and their community. And we really see that there can't be true quality of care. One of the things that we focus on intently in our work without there being equity, because our measures will show that when we're not reaching everybody, our quality of care suffers. And so we can't have quality without equity. And then I talked about that this is it's our vision is to lean into health equity for all, and think about it from a lot of different perspectives with the patients that we do serve. This is just to give you a little bit of a sense of where we've been and where we're headed. And so I talked about the history of the health center movement, our 2019 planning process that led us to the new vision statement of health equity for all. We were, of course, like you, just right in the mix with the 2020 what we call like a community realization around inequities that have occurred for centuries in our country, and some of the events that really caused there to be kind of a public or a community or a national reckoning. And as we came out of the pandemic and we were really working on our strategic plan, we spent a lot of time talking about leaning into our vision and what that would mean and what that would look like. And so created an inclusion council. You actually would have had our director of health equity here, but we have our inclusion council book club at the same time. And so our inclusion council has just done a lot of different projects over the last 3 years that is advancing our work internally, and then hopefully setting our staff and programs up where equity is embedded in them as we take different initiatives and projects out to the health centers to work with them. I'll spend the most time today talking about our AHEAD project, which is advancing health equity and addressing disparities. And we were very fortunate to be able to leverage some of the federal funding that came into the state in support of disparities reduction to really do a year-long planning process to develop our AHEAD implementation plan. So AHEAD is really the name of the journey that we embarked on back in 2022, June of 2022. And we really have made the decision to continue our work under that same name. We see it as being a culmination of the work that we have been doing collectively to advance health equity and address disparities. And we have created really an implementation plan that we envision will guide our work for the next 5 to 10 years as we try to systematically tackle inequities in the work that we do at the health centers. So just to give you a little bit of history of kind of where we've been and what our approach was in that first year in 2022, we had really 4 phases of work. And so we completed a health equity needs assessment in partnership with a consultant, an organization called the Primary Care Development Corporation. And we were able to really do an assessment at all 14 of the health centers that was both based on survey responses from staff, and then also facilitated conversations with community, patients, staff, and then health center leaders. That input, along with a number of other strategic guiding documents that we have, has really come together in what we call the AHEAD implementation plan. And then during that year, we were actively working on data strategy and did step into the training and education space with a couple of presentations that we have done. There's a lot more planned in both the data strategy and training and education space. We've also, of course, been thinking about sustainability and the ongoing impact that we hope to have through the work that we'll do over the next decade or more. And like I noted, AHEAD will continue to be the brand that we use for that work. This just gives you, for more of our visual participants, kind of what did the work look like, when did it happen in that 2022 time period, and how did these different pieces kind of come together. So you can see we did the health equity needs assessment was our first component, developing that plan, and then engaging our board and others in training and education. And then a big piece of our work at the association was to actively work on embedding equity in our other projects that weren't specifically called out in our AHEAD work. I wanted to share some of the assessment outcomes just at a very high level with all 14 health centers participating. And so we were able to get completed surveys back from close to 900 of the over 2,000 staff that work at the health center. So about 40% of the staff did respond, which we felt was a really strong response rate. And then I noted that we did the facilitated conversations with patients, community, and a variety of health center staff and leaders. And so through those facilitated conversations, talked to about 400 people over the course of a couple months. So the plan itself, really the purpose of the plan is to provide us with a multi-year collective framework that both our organizations at the state level can work on, and that also guides the work of the health centers in their journeys with their local communities. And our goal is to play a larger role in creating more equity in communities. We want to continue to embed the equity framing and equity lens into the work we do more broadly. And we also want to provide actionable guidance in terms of what steps health centers can take, and kind of what are the resources that it takes to move into I guess more robust or more mature phases of this type of work. So the big picture for us is to really identify 1 to 3 health outcomes with significant health disparities to focus interventions on in the coming year. And we're actively working with the University of Iowa to do what we are calling a disparities landscape assessment. And so one piece of our plan that we didn't have completed, and about why in a moment, was just really this deep dive in the data sets that both exist within our organizations, but also that are available to us, anyone from the public, to really see, thanks to our partners at the federal state level as well. And then from the identification of those disparities, we would like to set an achievable disparity reduction goal. And so really hold ourselves accountable and set that goal out publicly so that we are reporting back on the progress that we're making as a network of healthcare providers. Our AHEAD implementation plan, it's an 80-page or something like that plan. And so these slides are just kind of synthesizing the main components of the plan, so you get a sense of the areas that we really are working within, and kind of how the plan is organized. So we have 5 theme areas in which objectives, activities fall under. So we have our broadest one is our mission theme, which is really to speak to the integrated health approach that health centers take, and further leaning into integration. So if we have co-location from that perspective, is there a way to actually integrate those services further for our patients? That's something that really drives all the work we do. So wanted to call out the integration piece as kind of our mission theme. And then our other objectives and activities fall into these 4 other areas around people, operations, services, and community. So the implementation plan, we intend for it to hopefully be a bold plan where we are marching toward and working toward an impactful reduction in health disparities statewide. One of the pieces that we're trying to do in identifying these disparities areas in which we could work is to also engage our partners, because I think if we find that 5 or 6 of our significant partners are all focused in one area, that's a signal to us that this is an area where we might be able to have some greater collective impact. And we know that we need our payers, our state and local government partners, our public health agencies, our hospitals, and others to hopefully be working towards these same things, because no entity can do this work alone and have the impact that we hope to have. The plan itself allows for health centers to kind of enter this journey where they are. And so we've organized the activities into where there's suggested kind of individual actions that health centers can take that fall into kind of I'm early in my journey to, we feel a little more comfortable. We've put some stuff in place in our organization. We're kind of ready for the next types of activities to really more advanced activities. And so health centers are able to both select and operationalize individual strategies kind of based on the priorities of their communities and also where they are organizationally, which is, important, I think, when we think about the differences and unique attribution aspects of clinics and other organizations locally. The thing I'll note is that we, of course, consider ourselves doing this work over a long period of time. And so know that the plan itself will evolve and change and be flexible as we continue to be responsive to what's happening in our state. I'll just maybe talk a little bit about how we intend to both bring visibility and evaluate the progress on our plan. And so we have our Iowa PCA board and also our health equity champions. So there's a health equity champion at all 14 of the health centers. And they, along with many other groups we convene of health center staff, will really be responsible for governing the implementation of the plan and also helping us to make changes over time. I noted that we have a number of other existing work groups and committees. So we bring our chief medical officers together, we bring our behavioral health directors together, our dental directors, our front desk staff, just a high number of committees that do come in that we do facilitate, and the plan will also come to those committees to add value and bring visibility to the work broadly. And then we at the network, the PCA, we are also actively working to not only change the way that our organizations operate, but then how are we providing support on those individualized local strategies that the health centers are working on. And we have ways to do that through peer networking and other activities. This is just to kind of summarize the measuring for success. So kind of what you saw with the goal of having measurable disparities reduction in 1 to 3 outcome measures, setting a goal around that, creating a data plan to monitor our progress over time and actually sharing that publicly, and then capturing each year kind of what the individualized health center health equity priorities and outcomes are, as that's a huge piece of this broader accountability and puzzle that we are working on. This just articulates hopefully what our expected outcomes are for the 3 statewide strategies that our network, so the Iowa PCA and Concert Care and Iowa Health Plus, have committed to working on in this fiscal year. So our fiscal year is the July 1 to June 30. And this is meant to give the audience a sense of, in the data strategy space, what do we expect to be, where do we expect to be by the end of the year in terms of advancing our social determinant of health infrastructure, the training and education supports and services that we have available, and then the data strategy. The SDOH infrastructure focuses a lot on what many people are working on in our system, which is not only hopefully capturing better information about social drivers of health from our patients, but building out the interventions that are needed so that when we're screening, we have a place to send individuals who have an identified need. On training and education, we want our health centers to have the knowledge and begin to incorporate JED-ID principles, tactics, language, concepts into the training materials that they might have with staff, the patient-facing publications. And I think there's just endless opportunities around training and education. I can tell you a couple of places that we're working in our Inclusion Council is really around words matter and inclusive language, and then really developing a psychological safety framework. And so all of those things come with, of course, the need to provide training and education to staff and others as we begin that work or implement that work. Also wanted to give a shout out to Molina Healthcare of Iowa, who has made really the first investment after those state dollars for our initial AHEAD work, and funding is flowing to health centers from the Molina Cares Foundation and Molina Health Plan of Iowa to support the strategies that are on this screen. This is meant to give you a sense of kind of where are the areas that the health centers across the state kind of identified that they want to focus on and that they're actively resourcing and trying to build I can tell you for me, I'm thrilled to see the focus on patient or community engagement, and then the patient and family advisory councils. Health centers are unique because they have patient-driven boards as part of the federal requirements and really the model of being a health center. And this to me is kind of that next step of hearing from additional voices and knowing that your boards can't always represent all the voices and views and needs that communities have. Just got a couple more slides, you all, and then we can dive into questions and conversation. We also wanted to try to articulate, like, what does this success look like for us over time? Again, this is kind of an eye chart, so I will not read these things to you, but trying to articulate what we hope to be as an organization that is actively investing in belonging in JEDI and health equity. We also have this unique role of being a system of care that can prioritize health equity. And we, because of the data analytics infrastructure, we also have the opportunity to measure equity goals and strategies that really transform care in our state. So that is really the end of the slide deck that I put together, and I can't believe I did it before 12:30. That's very rare for people that do know me. I can be kind of long-winded, but I just threw together some questions that I thought could help get the conversation started, and all questions are welcome, all comments are welcome, and we just would love to have the opportunity to talk with all of you about things you're doing or questions you have about our plan as well. So I'll stop there and see what questions people have and what other topics they might want to talk about. I'm looking at the Jessica, thank you. So I see in the chat, and here I can just share too, so that we can. You guys, now we're just seeing each other. Is that the view? Is that right, Jen? Okay. So the question, do you have any concerns on the CMS, Medicaid, and Medicare ahead state total cost of care model being the same ahead as this program? It's a great question, Jessica. We're aware of that program from CMS. I'll say that we had our ahead acronym first, but also know that that's probably a pretty common acronym as well. And so I think what we have to do is just differentiate, because of the timing of that program coming out, what our work is here in Iowa and then how it does relate to the CMS model. I do see a lot of different kind of programs coming out now that have equity in their design. And so I just think it's one of those challenges of, trying to come up with ways to communicate in a clear and concise way with those acronyms, but then knowing that you other people have that great same idea. So I think we just have to be clear about, we're talking about ahead, we're talking about our work in Iowa among the health centers, and know that CMS is also actively working in some really good spaces to advance this work and value-based care as well. It's a good question.
You have a great acronym when you have competition, right?
Seriously, so true. Have any of you? I guess one question I might ask the audience is just like, was there anything about our approach that surprised you? Did you see that, just like blind spots that we might have had? I think that would be super informative if people have ideas or thoughts they want to share. So I guess just anything that surprised you or anything that you thought was missing, would love that. And of course, other questions too.
Anyone is welcome to come off mute. Feel free to join us on camera if you feel comfortable doing so.
Yeah, I have a new laptop that has like the light like shines when you're on like film or whatever, and I guess my old one didn't, so I'm like this like light beaming on me when I have my camera on.
Well, I do have a question for you, Sarah. Do you recall what framework was used in the health equity assessment portion of the project?
Man, I could probably find it, Jenna. Yes. There were some tools that the PCDC team brought to customize for our assessment, and I can take that as an action item to send back to you all, because I think I'll struggle probably to make that happen with my computer and trying to search for files here. But yeah, so it's like the framework for the assessment. Yes, they did use some validated questions and approaches. I will say one of the lessons learned we had, though, was some of the questions that we included in our survey. I think that the level of understanding of what the question was driving at or meant was challenging for different types of staff. And so one of the things that we would do differently if we did an assessment like this again is we would consider our audience more broadly, and, you know, think about like if somebody working in the front desk is being asked this question about like organizational policies and procedures or whatever, have we set them up to really be able to respond to that question? Do they have the knowledge, or is the terminology even the right terminology? And so I feel like we ran into that issue with the assessment, where we would do that differently, for sure. And then I had one other point about the assessment. The facilitated conversations were really a script that our Primary Care Development Corporation colleagues co-created with us. And I really liked the way that the script was set up. So I don't know if they actually used like a framework or not. The survey definitely, but it allowed for a lot of space to look at inequities or equity in a lot of different ways. So I liked our facilitated script a lot. And then I would have changed our survey tool for sure. What else? And I'm just getting myself something to write on. I'm so sorry, because I want to make sure I follow up with that framework.
There was one comment that says, great model, looking forward to how it could work in our rural communities.
So that I could pick up on the rural piece a little bit from that, Jessica. I think the conversations they did feel different, in our more rural sites. And so over 50% of the health center sites are located in rural areas. I think from HRSA's perspective, all of our health centers are actually considered to be rural health centers in a state like Iowa. Some of the things that I would say I observed in the facilitated conversations, that, it was hard because there's these emerging issues like persons experiencing homelessness that are much more prevalent in our rural communities than maybe they were before. We've always had individuals experiencing homelessness all across our state. But one of the things that came up in the more rural or micropolitan conversations was we see this more, and we don't have the same infrastructure that our urban counterparts have. And, trying to think about and make sense of like, how do you, the solution, when maybe you don't have those types of services, like, is it just emergency homeless services? Are you actually trying to build out like a healthcare and housing model that maybe leverages some different investments and infrastructure? So some of the needs in the rural communities, I would just say, were maybe, I don't know that they're emerging needs, but like way more significant needs, and really seeing that there's not the services and the array of services that exist in our urban city centers, which I don't think is a surprise to anyone, but it was just very acute, is what I'll say. Jessica, another question. Is there a plan to expand the areas of the state where your services are not located yet? That's a really great question. That is an area that we do work in. So I can talk a little bit about our statewide strategic growth plan. We, in just a couple of years ago, did a real deep dive on unmet needs in terms of access across the state, and have a very robust data set, kind of county by county, with a lot of different indicators that a student actually pulled together for us. But more specifically to the health centers and their ability to expand and grow, that's one thing that we do work with them on from the PCA perspective. And so sometimes those things occur organically. So I'll give you an example of Eagle Grove. So we had learned just more happenstance that a dental clinic was going to be closing in Eagle Grove. And the CEO of the health center in that area really pulled some people together and said, what, is there an opportunity here? And so from those conversations with the dentist retiring, the health center did buy that building and has not only restored the dental services, but then also added medical services to a community that did not have a clinic previously. And I think is considering also behavioral health services there. So that's one, like a success and kind of a dark time, I think, for a lot of us doing work in community health. The other ways that sometimes that'll happen is health centers also, they do, some of them do individual market analysis, and then they'll actually say, like, we can see and we know that so many of our patients are coming from this community. They'll try to put it into their strategic plans to maybe build out a new site. After COVID, more of them are exploring virtual options. We have seen health centers engage in a lot more of them have mobile clinics, for example, or are doing school-based healthcare. So I think there's a lot of different opportunities and ways to grow, and it can be done in partnership with organizations that can see that the population they're serving, so in a school, is lacking access to care, and bringing those services to the school is one of the best ways to make that easy for patients and families. And then in other cases, there are sometimes federal funds that will come out that allow health centers or new health centers to be built. And so we always look at those opportunities to see if we could be competitive. I'll say that Iowa struggles to be competitive from a need perspective when HRSA is looking kind of across the country. And so a lot of our growth and expansion strategies have to be really funded or developed without those federal dollars. And so health centers certainly come to the table with our local economic development people. Sometimes they can leverage USDA funding to expand. And then we're available really to just provide TTA and also point them to the places from a data perspective that we can see a lack of access to care. So hopefully that answered your question. Yeah, Randy, I see your hand is up. Go ahead. How you doing, Randy? Good to see you. And we cannot hear you.
You'd think we'd learn how to do these now. Okay. Thank you. We certainly work with you guys. We contract with you on some projects and things like that. And so I'm wondering if you can talk a little bit about where you see different intersections or, changes in the work that we've been doing based on your health equity plan, and how we get a copy of it. We're working on our implementation plan for the Stop HIV Iowa plan, and FQHCs certainly come up in our plan, addressing, routine testing for HIV, STI, and hepatitis, which is what we contract with you for. But I'm just wondering, do you see different intersections with us or different ways of working based on the plan that you've developed?
Yeah, thank you, Randy, for the question. I can answer it maybe in a couple of different ways. Well, number one, we definitely can share a shortened version of our plan with our external partners. So that's something that we're happy to do. I know our communications team is working on that. Our board just approved the implementation plan on October 11th. So we're just about a week out of that, and actively working to get that document so it's available for all our partners. I think the two other things I'll say is, one of the things that we're trying to do systematically, and our Inclusion Council really leads this work, is to go kind of project by project or initiative by initiative and say, in our project planning, how are we applying a JED ID lens to the work that we're actually planning? So whose voices have been left out? What are our blind spots? what are the ways that we can actually use the way that we plan our work to embed health equity. So I feel like for a lot of our projects will start to bring that lens, and it might help us to make a shift in maybe the activities of focus or some of the outcomes that we're looking for. We've started that work with our strategic projects. So we have 10 strategic projects in our strategic plan, and all the teams that are actively implementing those are using having an inclusion council member actually come to a planning session and really walk through a set of questions that help us look broader and try to identify those blind spots. I see us doing that with all of our other work, our partnership work as well over time. So I think that's one way that we could look at that from our perspective and come to a partner like you and say, hey, we've been doing this work with you. Here's some insights or things that we have thought about from an equity perspective when we actually asked ourselves, what are our blind spots? You know, what could we do to advance health equity here? And then I also think like with other organizations, so you referenced the Stop HIV plan, we also need to be like looking at those plans and saying, hey, I see the state has set out this goal to reduce an inequity. What role could we play in supporting that? And for the 1 to 3 kind of health disparities that we're hoping to just like, we're going to hone in on these and we're going to set a goal for reducing disparities. We have to have those line up with what the state is thinking about from the priorities that they want to resource and work on. What are the MCOs kind of focused on? And so like I mentioned earlier, we're trying to get input from our partners in addition to just looking at the data to say, is there something that we could actually run at together? So those are a couple of ideas, Randy, and I don't know if that answered your question, but happy to, if you want to follow up with anything else too.
Sure. No, I mean, I'll be interested in looking at the plan, and as we're working on our implementation plan, I think we'll be doing the same thing, looking at where we can find commonality, and you know, maybe we'll be focusing on slightly different things, but you know, obviously working together on this.
Yeah. And I would say, Randy, too, like the other thing I didn't cover is like sometimes the work we do is like broad. Like we're trying to like for example, screen an entire population of patients. What I wonder sometimes about is with this more intentional focus, will we actually say our goal is universal screening for everybody, and we're actually going to resource our outreach and focus and all the tools that we have on populations that are actually having less access than everybody else. And so I do wonder if there'll be some more, you know, specific targeting that we do try to do, which we try to do today, but I could see us doing it maybe better, more intentionally, if that makes sense in the future.
Yeah, sure. Thank you.
Yeah, absolutely. I saw Jenna shared the evaluation, which is great. Yes, definitely pull out the evaluation.
I wanted to make sure I got that on there if anyone has to leave early. I do have one more question backing up to right before you started the AHEAD project. Was there any barriers or challenges in getting the Inclusion Council started and off the ground?
It's a really great question. Let me think about this. I would say, okay, so here's what worked well. We had very enthusiastic staff. So one of the problems we didn't have was staff wanting to engage in the work. I think that the challenges that we maybe experience and have kind of had to work through over time is that you can do so many things in these inclusion councils. And so we tried to spend a lot of time thinking about our charter. We tried to use our strategic planning and kind of project management tools to actually identify and scope a couple projects that we could really focus on. One of the things that we tried really early on was actually like a laundry list of all the things that we could do. And it's endless. And so I feel like one of the keys to success is like capturing those things, but then prioritizing and actually spending your time in a couple of different places. And so our team has thought a lot about what are some of the foundational components that we need to do first. Our charter helps us, I think, really guide the things that might be out of scope for the Inclusion Council. And then some of the things that we've done in the meetings to help people feel more comfortable in these spaces where you're like, you might be looking at a policy and saying, like, actually, this, we've always done it this way. Actually, there's really some things about this policy that are not inclusive and are, actually reducing belonging in our organization. And so we've intentionally spent time in our meetings on what we call learning moments. And so bringing kind of different topics that our Inclusion Council members, like they actually get assigned to bring forward and facilitate. So the one today was on digital inclusivity. And so there was a couple of videos about some of the innovations in the tech space that are really bringing so much more belonging and connectedness to our individuals with different disabilities. And then we bring those out to our staff meetings as well. I've been all over the place, Jenna, with the Inclusion Council, but I would say other difficult things is we had to also be really intentional about carving out time in our operational work planning. So trying to give people the space and time that they need to invest in this work. So, we, I think, have gotten better at that. And now people know to kind of plan it, plan their time when they're serving on the Inclusion Council. The other thing I think is just, it's like you need almost like a whole set of language to sometimes have some of these conversations. So it's like you need to skill build at the same time that you're trying intervention. And so it's like this delicate dance of like, we're skill building. Now we're going to try this thing. Now we saw that like people are struggling with, I don't know, a difficult conversation in this space. So now what skills do we need to bring? So I don't know if that makes sense, but I would say that's, maybe a couple of things that have worked well and that have been challenging about our Inclusion Council. Do you have follow-up questions, Jenna, at all? Or
no, I don't. That's exactly what I was looking for, is just I would imagine, as with starting anything, there's always some challenges and barriers, and but it sounds like having enthusiastic staff really led you to be successful as well, which is wonderful.
Yeah, we did like an application process because we wanted people to articulate kind of why are you interested and why now? And, and I think that did help people really think about like, what's my motivation and what am I trying to not only bring to the table, but also maybe get out of Inclusion Council. So I thought that application process, it wasn't so much to be a barrier, but more like gave us insights as we were starting it into what people are really hoping for and their expectations. So it gave us a chance to kind of level set all of that by having people articulate those things as best they could kind of on the front end.
Wonderful. Well, does anyone else have any other questions?
I'll ask while people are thinking, I don't know if anyone can speak to this, but are there disparities that like IPHA has called out specifically that you guys are working on, or would you point us anywhere in terms of like this disparities landscape assessment that we're doing? So that's just one I'll throw out there if people have thoughts about that. And then of course, if people have other questions, that is great too. I'm not seeing anyone come off mute. And I guess maybe one other thing just is as you kind of heard the approach that we took, do you guys see opportunities for partnership, like things that you'd love for us to say back to the health centers? I'm thinking that a lot of the audience are probably from our local public health agencies, although I know there are many others as well. But just like any opportunities you throw out there that you'd like us to make, the health centers or our own team kind of aware of that's happening in the public health space or otherwise, we'd welcome that too. I am not seeing people jump off. Jenna, do you have anything else
My
for
crew,
me or
everyone's
other?
hungry.
No, yeah, right? It's like lunchtime.
I don't have any other questions that I'm seeing on my side, so, like I mentioned, if everyone could take the evaluation, the link is in the chat. And the recording will be posted on the IPHA YouTube channel as well if you want to rewatch this. If you think of anything else, feel free to, message IPHA or reach out to Sarah directly.
Yes, and I will just note that the two takeaways and I can just send these probably to you, Jenna, would be that external plan that could be shared with the participants from today. And then I'll also find out the name of the framework that the consultants use to help us develop the assessment. So that's hopefully a resource to everybody as well. But yeah, please reach out anytime. We're happy to connect with everybody or anybody. And just thank you for the time today to talk with you all, and hope you guys have a great rest of the day.
Well, thanks again for joining us, Sarah, and I hope everyone can join us for our next Lunch and Learn session in November.
So thanks, Jenna.
All right, take care. Bye-bye.
Bye, everybody.